Thank you for joining us for another installment of the 5 things you need to know from the AUA meeting. My name is Max Cates. I'm director of the Division of Urologic Oncology at the Brady Urological Institute at Johns Hopkins. And today we're going to be talking to Dr. Nirmish Singla, who directs the kidney cancer program here in urology at Hopkins. And we are going to learn about the 5 things you need to know about kidney cancer from the AUA meeting. So take it away, Dr. Singla.
Thank you so much, Dr. Cates. I'm more than excited to share what I would feel are kind of the main contemporary themes that came out of the AUA for kidney cancer. The way that I would sort of maybe group these 5 categories are into different buckets that I would say that there's an active degree of research that clearly is ongoing from what we've learned at the AUA. And we're certainly excited to see how these continue to evolve in the forthcoming future. So happy to kind of give a quick overview, and then maybe we can chat about some of the advances in each of these areas. As a disclaimer, this isn't by any means comprehensive. I think that five themes out of the AUA, of course, is not going to be enough to cover how much we really have ongoing kidney cancer work. But the way that I what I took away from the AUA conference, I would say, are one, we're clearly in a phase where there are new molecular diagnostics, and this extends to small renal masses and localized kidney tumors. 2, we're seeing that small renal masses still have an active role for research and new therapies and new trials. And so this was another theme that I saw coming out of the AUA. 3, surgical education, and specifically surgical education for partial nephrectomies and surgical approaches to treating, robotic approaches to treating kidney masses has started to see more of a revolution. And this was something that was big at the AUA this year. Number 4, I would say that for locally advanced kidney cancers undergoing surgical treatment, we're starting to see more and more use of perioperative therapy and multimodal approaches to treatment. And then the 5th big thing that came out of the AUA this year, I would say, is continued mounting evidence for the role of the urologist and the role for surgery in metastatic disease. And so happy to sort of go through each of these one by one, but I would say that as a summary, those were kind of the big 5 themes that I took away from the AUA this year.
Okay, so that's a great list, Dr. Singla. So let's go through that, through those 5 things. So the first thing it sounds like you need to know is that molecular diagnostics in kidney cancer are sort of coming finally into clinical utility and clinical use. Can you kind of give me some examples of what you saw from the meeting?
Definitely. So as we know, renal mass biopsies as a whole over the last several years has started to fall out of favor. They're very limited. And in particular, we sometimes see a lot of heterogeneity within tumors. Sometimes we can see false negatives with biopsies. They're invasive. And so as a result, there's started to become more interest in either developing newer agents or turning to the use of artificial intelligence to inform about renal tumors that are incidentally detected. So with respect to novel diagnostics, things that we saw at the AUA this year included updated contemporary experiences with what's called the SESTA-MIBI SPECT CT scans. And this is actually something that was developed at Johns Hopkins several years ago, but we can see real world practice has shown that SESTA-MIBI scans still have a great ability to differentiate benign masses called oncocytomas from malignant renal cell carcinomas. We also saw more evidence that came from what's called girentuximab, and this is a novel PET CT tracer that was recently approved by the FDA for diagnostic purposes for patients with clear cell renal cell carcinoma, being able to differentiate clear cell from essentially a non-clear cell forms of tumors. And this is an agent that targets CA9, which is a target that's seen specifically in clear cell renal cell carcinoma. And then we were also seeing more data emerging from the use of multi-parametric MRIs, what's called a clear cell likelihood score. And so I think more and more we're going to start to see that these types of scans may begin to complement one another more and more, and be able to hopefully completely supplant the need for biopsies and informed treatment. Furthermore, just in terms of the heterogeneity that we're seeing pathologically and then also radiographically in these tumors, we saw some studies at the AUA this year that also informed the use of artificial intelligence and machine learning. And I think that this will also be something that we'll see more of in the near future.
That's fantastic. So the second thing that you mentioned that we need to know from the AUA is advances in sort of our understanding and management of small renal masses. Can you tell us a little bit more about that?
Certainly. So with small renal masses, we have learned over the years that they are not typically life-threatening. And as a result, active surveillance has largely become an area of focus for a lot of these patients. The thing about small renal masses, though, on active surveillance is that this can also often be a source of anxiety for a lot of patients and negatively impact quality of life. Sometimes we do see slow growth for small renal masses on surveillance. And so as a result, many patients are seeking alternative forms of treatment that may not be as invasive as subjecting them to surgery. And so there was at the AUA, a couple things that were clearly seen. One is that there has been now more longitudinal evidence from multiple groups attesting to the safety of active surveillance. And so I think that that's something reassuring for patients when counseling them on this option with small renal masses. The other thing is that we're also seeing a novel technology emerge, something called histotripsy, and there's actually now a new clinical trial that is currently active called Hope for Kidney, led by Histosonics, which is essentially a completely non-invasive, focused ultrasound approach to treating small renal masses using cavitation bubbles. This is a technology that's currently FDA approved for the liver and has been investigated in other settings as well. And we're very excited to see what the results of this trial will emerge as with respect to treatment of small renal masses.
So, I can't help but think about combining, when you think about both of those top two things, it's really about identifying how we can reduce overtreatment in kidney cancer and maximizing appropriate treatment. And that strikes me as being true both for molecular diagnostics and for small renal mass management.
Absolutely. It's always a shared decision-making approach whenever a patient presents with a small renal mass. And it's one of the few cancers for which it may be the only cancer for which you don't get a biopsy before you make a treatment decision. And so I think as much information as you can get ahead of time and share with the patient can often really be helpful in terms of counseling each patient on an individual basis, taking into consideration both patient-related factors and tumor-related factors as well.
So one of the most exciting aspects of the AUA is, of course, all the videos that are shown and all of the advances that many of us are doing here at the Brady, but definitely outside of Hopkins and outside of the United States. And I'm just curious, your third thing that you need to know is surgical education, specifically around robotic education and partial nephrectomies. Can you tell us a little bit more about that and what you got out of the AUA from that standpoint?
Absolutely. So we are starting to see more expanding platforms for robotic surgery as a whole. For example, with the introduction of the single port robot, with introduction of alternative approaches to accessing the kidney. Classically, when partial nephrectomies were first described, they were traditionally robotically, they were traditionally done via transabdominal transperitoneal approach. But now, in an effort to reduce morbidity of the surgical operation, perhaps reduce the risk of complications, more and more videos are emerging with respect to retroperitoneal approaches where you can avoid the intra-abdominal structures altogether. And even combining that with the single port platform, having just a single incision in the retroperitoneum, getting to a tumor safely and as efficiently, if not more so, and resecting it in a very effective manner is something that many are starting to show increasingly in videos and with respect to their series. Undoubtedly, partial nephrectomies in general, there are some that some would consider are very simple cases, but sometimes they can be very complex as well. And there is certainly a learning curve to overcome with those operations. And so any way that this operation can be made either easier or with less complications certainly can expand the toolkit of a urologist, especially for the harder or more challenging tumors. And on that note as well, credit to Dr. Ghazi, who's here at the Brady. He has launched a very successful program with respect to three-dimensional models for surgical education, and actually has made a number of models that he showcased at the AUA this year. To practice for complex partial nephrectomies, and that certainly was a big hit. It can be helpful not just for the learner trying to learn how to do these operations, but also almost like a rehearsal model for practicing urologists to ahead of time see what the landmines are for an individual patient. A 3D printed model of a patient's exact anatomy, the vessels, the nature of the tumor, how endophytic is the tumor. And so this is really a great opportunity, I would say, for both learning as well as practicing in a way to minimize complications when actually operating on a patient.
Yeah, that's really fantastic. Clearly, how we learned surgery will be a thing of the past, in the coming years as technology and models like Dr. Ghazi's kind of changes the face of surgical education. So let's look at this fourth thing that you need to know in kidney cancer, which was the management of locally advanced kidney cancer, specifically around perioperative therapy. I'd love to hear more about that.
Yeah, absolutely. So, with respect to locally advanced kidney cancers, classically the gold standard treatment approach would entail surgical treatment, followed by simply just observation. But the issue that has been a pervasive issue for at least a couple decades now, if not more, is that unfortunately about a third of patients may recur despite undergoing surgery with so-called curative intent. And so, for the first time, just actually last month, the mature results from the Keynote 564 trial came out, which was the use of adjuvant pembrolizumab for patients with locally advanced kidney cancer. And what they found is that actually, in addition to improved disease-free survival, for the first time, we're also seeing that overall survival was also significantly improved. And at the AUA, results from this trial were also shared. And in addition to that, I think there were more discussions surrounding the expanding role for the perioperative toolkit. Certainly, we're going to continue to see actuarial utilization of perioperative therapy increase thanks to the results of this trial. But in addition to that, what we're really excited to see are how novel combinations of drugs, either entirely in the adjuvant setting or potentially in an approach that entails neoadjuvant or neoadjuvant plus adjuvant combination strategies, may be rationalized and may also expand our toolkit of what we can offer to patients aside from simply just surgery alone. I think a big thing in this space would be personalizing that as the next step. So now with increasing attention, as we saw at the AUA this year, towards identifying predictors of recurrence and finding out which patients are bound to recur, trying to better strategize and parsimoniously choose which patients would benefit from perioperative treatment strategies.
And it seems to me that that's going to mandate sort of multidisciplinary care in kidney cancer. And along those lines, when somebody has metastatic kidney cancer, there's been a lot of debate, especially in the last 5 to 8 years, around the role of the urologist. And so I love that this fifth thing you need to know is that there is still a role for a urologist for metastatic kidney cancer. I'm wondering if you can tell us a little bit more about that.
Yeah, it's a great segue into sort of that fifth bucket of information from the AUA this year. So when it comes to the role of the urologist, I would say that the pendulum has kind of been swinging back and forth over the last couple decades, specifically when we're talking about cytoreductive nephrectomy, or essentially removing the primary tumor in the setting of having metastatic disease. And this was initially something that was favored in the cytokine era, and that data was extrapolated throughout the earlier portion of the targeted therapy era, and then it was brought into question in 2018 because of the Carmina trial, which sort of led to some more questions about whether or not cytoreductive nephrectomy was relevant. Now we're sort of in a data-free zone when it comes to prospective evidence in the contemporary era, which is classically termed the immune checkpoint inhibition era, just because that is this newer form of therapy has largely revolutionized kidney cancer treatment within the last 5-10 years alone. There are ongoing trials, the results of which are still immature and have not yet been presented. However, we do have mounting retrospective evidence, including some that were presented at the AUA this year, that does demonstrate that cytoreductive nephrectomy is certainly both feasible and safe in patients who have received prior immunotherapy. It is feasible also for using minimally invasive strategies in these patients, and also is now starting to show oncologic benefit as well compared to those who are carefully selected but don't receive cytoreductive nephrectomies. And we're also now starting to see some of the correlative data in patients who have received systemic therapies and subsequently underwent surgery, finding out more and more about what is actually happening in the tumor itself from these types of therapies and how we can predict responsiveness. And so I would say that right now we're still ripe for prospective evidence, but from what we can see, definitely from the AUA this year, the urologist still has to play a critical role in managing patients with metastatic disease. And then site-directed therapy also is an important theme for patients with low volume or oligometastatic disease, where sometimes use of radiation or use of surgery may be beneficial for those patients too. And so, like you said, multidisciplinary consultation, very important for metastatic disease, even still.
That was a great list of the 5 things you need to know from the AUA meeting from Dr. Nirmish Singla talking about kidney cancer. Please stay tuned for future episodes of the 5 things you need to know in other disease areas within urology.